Now we would like to have the opening lecture. This session will be chaired by Dr. Yoshiyuki Ueno, and the presenter is Dr. Masao Omata, Steering Committee of VIPASL. Dr. Ueno, please.
Okay, now we are diving into the first and most important scientific sessions. And this lecture will be given by Professor Masao Omata. And as a Japanese, it is very difficult to call him as Masao, as a person called friends called. But well, it's my privilege as a chairman to introduce Masao in this audience. This is my first time, maybe in the public audience, to call him as a Masao, but well, this is my very honor and privilege. So everybody knows Masao, and even after he retired from the Tokyo University and current Yamanashi Prefecture Hospital, his academics interest or curiosity increasing day by day, and he's productive day by day. It's amazing. It's a kind of miracle. But well, in this talk, he will give us not only for the in view of liver, but other organs and current movement towards oncology. Professor Omata, please.
Morning. ありがとうございます。まだちょっと眠いんですけども、頑張ってやります。But I'll never be called Masao by Ueno sensei because even myself never call him Yoshiyuki, so that's a bit odd. But anyhow, we can get started. Professor Ueno, the title of this my talk is 45 years of Apostle. The history, if you go back, maybe 1978, 45 years ago, Okuda and Powell. I even never called the Kunio, by the way. It was biannual meeting, but regularly 600, 700 attendants. In 2005, we took some initiatives to make it instead of biannual to annual meeting, starting single topic conferences such as this one. Then we started Hepatology International, published by Nature Springer. Then participants of annual meetings gradually increased, and then height was maybe the one held in Shanghai. But unfortunately, because of the COVID-19, it declined. But still, we continued in this COVID-19 era to run the apostle, such as webinar seminars. We did 45 times, School of Hepatology 16 times, and best publication now just started, HepI, 3 times so far. Then RCAP, this is about hepatocellular carcinoma, and 6 times. Altogether, 71 times for this 4 years' time or 3 years' time. And YouTube subscribers, if you compare the other societies such as ASLD or EASL, it could be like almost equal to ASLD, a little bit behind from EASL. So these are the activities we are doing for the last maybe for 3-4 years, COVID era. Shina-sensei, you can take a picture if you want. And Apostle single top conferences. From 2006 we started, and 45 times in 18 years. And maximum times 8 years. As you know, the Asia is so wide. So single topic is not really a single topic. Sometimes try to be educative for the societies on patients. And the participants for single topics naturally varies because the region, location such as Mongolia, you may have 300. That's almost equivalent to the numbers held in a big country like China, 3,000 maybe. So I think this single topic plays a very important role for the educational fields of the hepatology. But not just that, that's kind of the focused conferences. And naturally, we are rotating all over the Asia. So this was started in 2006. Until now, we are going to have 45th one. This is the one, the 45th one. And because it's a focused meetings, we do by under the title of HBV, CV, CC, or NASH. Then we did the hepatocellular carcinoma conference 5 times, but then changed the title from SCC single topic to oncology. And then first one is held in Tokyo by Moriyama sensei. Then second, Takamatsu by Masaki sensei. And the third was Sendai now, as Dr. Ueno said that this is the first time in the northern part of the Japan. And then next year, in Chiba, Professor Kato is planning to do these meetings. The mission of the personal oncology varies, but obviously, especially in Asia, virus elimination, China B and Japan C, and also the treatment of advanced SCC cures. Discovery SCC back to 1989, 33 years ago. And then we did, as others, pivotal trial 2013 in Japan. And this is one of the pivotal studies we done in those days. And then 2013-14 we published. And then the health coverage, government insurance coverage started 2015. So huge number of the patient treated. So in fact, year 2023, my outpatient clinic, mostly SVR patients. I do the outpatient clinic 2 times a week, and usually I see 30 patients. But still, we see new changes of the patients. It's amazing. For example, last time I had a patient suffering from the intrahepatic cholangiocellular carcinoma, even though he had a totally normal liver, but the CA gradually increased, and then we caught it. And then just before I came here, I saw the patient almost simultaneously, hepatocellular carcinoma and then esophageal cancer developed in the age 60. So it's just an ordinary outpatient clinic, but still I'm very careful about how to handle the patient because they are becoming seniors and then try to, and getting all sorts of the hepatocellular carcinoma, not just hepatocellular carcinoma, but other malignancies. Then it's WHO claim or proclaim HCV eliminations 2030, which means we got to prove, but how do you prove zero? In other words, if it's a very 100% fatal disease, it's obvious, it disappears. But asymptomatic HCV carriers, how we should do to try to claim it's becoming zero? Maybe it might be very tough. Near zero is possible, but totally zero is very difficult. But how close to virus eliminations? Real-world data in our hospital, I just show you in the subsequent 2 slides. Our hospitals are located in the west of the Tokyo, then HCC highest in eastern Japan. And because of the schistosomiasis epidemics in the old days, and then they use an infusion treatment. Therefore, many people are infected with HCV. So maybe this is a pivotal area to see, to watch, monitor the decline of the, and then becoming close to the eliminations. So in 16 years, 179,000 patients in our hospital checked about positive rate of HCV, and it was declining markedly. But this is antibody, therefore the viremia you got to be checked by this RNA determinations. And next one is, so that the peak was 8.9% and down to 2.3%, but in recent 3-4 years, it's a bit sluggish decline. Then we check the cbRNA positive rate among HAB positive, SCB-AB positive patients. And it turned out 2015 is a turnaround. It's markedly decreased. But maybe from now on, more difficult time we are encountering because you can claim zero. So I'm having some planning to do this, and maybe pretty soon we are sure very close to zero, but not stationary survey and near zero strategy should be conducted. Otherwise, just a gradual decline and never be able to say eliminate it. Virus elimination is one very important goal of our society, but of course, for this topic, advanced hepatocellular carcinoma cure. Well, about the small one, even I'm checking stiff liver, find the tumor small by nearby station, and then find small. This is one of the way we are doing. And then just Shina sensei is doing a lot. In fact, maybe he has the most experience on this kind of treatment. So find small and treat by RFA. It's a really unique strategy in Japan. CBAR elimination finds small and then RFA. In fact, annual number of the patients treated in the University of Tokyo, supplied by the Tatei sensei, is showing the peak was 2009. It just happened to the time I left the University of Tokyo. Then Shina sensei left, and there's a sharp decline, I think, 2013. But that's maybe equal to the decline in the occurrence or annual deaths of the hepatocellular carcinoma. I think maybe this phenomenon is starting in Taiwan as well, or Korea. I'm not sure about Korea, but Taiwan is certainly declining. So we are partially succeeded in this aspect. And then China may have some difficulty, but I just came back from China and saw the Dr. Wei Lai, who is the incoming president-elect of APASO, will have the APASO annual meeting 2025. And he said now the antiviral for HB is $1 a month, which is affordable. So if you find a patient, just give the drug and suppress the virus, not the virus elimination, but the suppression might be possible quite easily in China. So I'm sure that this may happen, and I hope this does happen in the other country in Asia. And this is the time I graduated medical school and then went to the States and came back in 1979. Then peak reached 2002 to 4. How about advanced ones? Drug trials. And this might be discussed in this meeting a lot. But if we make it short, these are the trials held by the companies and the effort of the doctors. And if you take a look at the MST, Solar, Lego, Lemba, Cabo, RAM is 10 to 13 months. Then placebo is 8 months, approximately. So 2 months differences. Then the combination therapy came. And then somehow it's prolonged, but also solar control prolonged. So the difference may be 5 months. Then we thought maybe it can be a silver or golden blood, whatever. We need a big step forward, which is understanding what's going on inside the cancer cell, and then to find the drugs. Guide to the drug. To further improvement, the precision medicine is talked about a lot, possible in hepatocellular carcinoma. We have to look for the drivers in individual cases. And then I created general analysis sensor, and then we did a lot of things for the last 10 years or 13 years. How to control the confidential data, how to follow them 100%, and then how to set up the computer systems and such. And then we have a closed area to control all these things. Then we collected more than 1,007 tissue frozen and then 42,000 blood and then liquid. By doing this and then set up the MGS laboratories, we examined 10,000 tissue samples, and then reference means we published on these, especially many on lung cancers, not many on the hepatocellular carcinoma, a little bit on the biliary. But recently, we did a lot on the COVID-19, and 25 papers we published. So as we doing this, we are getting closer to find driver mutations or oncogenic drivers. The scenario number one, if we are dealing with a certain organs, there is several scenarios can be solved. For example, if there is a drivers present, for example, if you take a look at lung, there is Oncomine DX, which is a commercial, which is available in the hospital as a routine almost. And then look at this one. There are so many mutations, and the individual mutation have drug appropriate, which prolong the life, not a matter of months, but a matter of the years. So this is remarkable. Like EGFR, well, when it got started, the gefitinib, people didn't know even there is a mutation, but turned out later on it was due to the mutation. Therefore, there is a pulmonary complication occurs those without drivers. So you got to look for the drivers. Then 42 months it's almost routine in the hospital, 297 cases. And look at this data. This is a divergence of the treatment. In other words, so much difference with, without driver, and then adapting the appropriate drugs for that. This is a famous adjuvant Adaura trial, but now another drug is coming, try to catch osimertinib, targeting the same driver genes. So this is becoming a hospital routine, and the results are outstanding. In other words, patients can be partially relieved. We have a RWD because we are one of the 51 cancer centers in Japan. We have to register all the cases. So far, we registered 30,992 cases prospectively for almost how many years? 17 years. And these are the cases, the number, but not just the numbers of the register. Government support us to follow these patients, dead or alive. In fact, until 2015, follow-up rate was 98%, because if you do this one in your hospital, only 60% follow possible. But if you ask the government or cancer center, then follow the rest, and then the follow-up rate is 98%, which is a remarkable thing to do, and then governmental support. Then lung cancer, such a dramatic change is expected. And in fact, every 3 years, we are able to follow them. This is just every year, of course, we are following, but this is just show the documentation sake every 3 years. And then it's obvious it's becoming. So if you have a pivotal trials, we are the network having to tell patients are relieved. In other words, really prolonged or not. We have the system. And then if you take a median survival, the recent case is not even reached yet. So this is the lung cancers. Among the solid cancers, solid malignancies, is so remarkable. Scenario number 2, drivers present, but no drug available. For example, LAS. And then how it's gonna be developed. And then for the last maybe 3-4 years, it's becoming so dramatic changes occurring. In other words, NIH decided to develop the last maybe 15-17 years ago. Also, the people get to the NIH and try to find drugs for RAS mutations. But unfortunately, RAS is very slippery, no pockets at all. But finally, they identified the pockets exist in the GDP RAS. In other words, before becoming GTP RAS, GDP RAS showed the pocket, switched to number 2 pocket, which might be the target of the drug. Then suddenly it started. And of course, these two drugs are on the market already, but as once it got started, so there are so many companies going on. In addition, not just this type, but molecular glue. In other words, even though it's very slippery, but you attach the glues, in this case, the cyclophyllins. If the cytochrome attached to this molecule, the molecule bends and then doesn't function. So that can be a blocker for this RAS, and there are several companies doing this. And then product degraders, this has a wide application, so they are trying. So about basically 3 targets, 3 ways of the inhibition might be possible. Then now, ESMO is going on, and then news release, October 23, so 3 days ago, they released in the News in Brief, Nature Revenue Drug Discoveries, RMC 62336, not even mentioned in the previous slide, glue-based KRAS inhibitors. And then not just G12C, but the DVRA targeted, and 38% effects in lung cancer, and then pancreas. As you know, the 98% of pancreas has carrying this virus. So if you got to pancreatic cancers, maybe that could be the one we really need it. And objective response is confirmed. DVR, somehow A is not mentioned, but anyway, covering most of the RAS mutations. And this first-in-class water plot was like this one. So I think side effects or complication may be a different matter, but maybe again this one rushed in, and then so many drugs candidate will appear pretty soon. So this is the one with obvious drivers, and then we are waiting the pancreatic cancer, how those drugs produce in the real world data in our hospitals. We are waiting, catching, monitoring, observing. And even the pancreas, there is a bit of the progress, but from 7 months to maybe 10 months, early detection may contribute this one. Of course, surgical effort is another one. So we have a setup, the finding driver mutations and watching, monitoring the outcomes in the field. Scenario number 3, there is a few drivers. Of course, if you analyze every single cancer, you may find 2 or 3 drivers, but not necessarily druggable. And hepatocellular carcinoma is mentioned so many times and will be mentioned in this meeting as well. What's a driver mutation? Maybe if you take PIK2, maybe TP53, and then into beta-catenin pathways, and in fact, the drugs to develop into beta-catenin is now going on. I saw the ASCO papers by Eisai company. But what the situation is, however, essential occurrence is quite different from others, because if you take lung cancers, wherever you take, drivers are the same, constantly. Take 20 different lymph nodes, or 5 years later, drivers are almost the same. Gastric cancers may have a different drivers sometimes. So we checked the 200 cases, and then many of the studies already show that genomic profile of hepatocellular carcinoma 5-7 years ago. But in clinical basis, they are not necessarily being followed, carefully checked, and then detected the abnormality, genetic abnormality. So in these 197 cases, patients, solitary cases 130, and in 20 we took different portion of the nodule and check it. And the multiple one, there are several types. Synchronous one is the same time there are multiple nodules. And metachronous is time difference, 3 years ago and then this time. And both, maybe simultaneous and later on metachronous. So these different types of the mutation, in this talk, just focus on the into beta-catenin pathways abnormalities. It's rather simple. Solitary, this is as was reported. Into beta-catenin abnormality was found 36% cases. This was concordant with the previous papers. But how about the multiple ones? Synchronous one, 13.5% nodules carry this one. So even though there is one nodule has a Wnt beta-catenin abnormality, but others are not. And then the metachronous one, the different time frames, there is also the different driver they are carrying. And then synchronous, metachronous. This is kind of the one nodules may be spread all over. Therefore, there are occasional cases in that inter-beta-catenin alone will be dominating, and then therefore it looks like it's a Wnt beta. So designation of the one drivers is sometimes may be difficult, but can be very dynamic changes can be seen in hepatocellular carcinoma. This is a bit different from the pancreas or the other cancers. So in these cases, more than 1/3 of solitary nodule, as was previously published, Wnt beta-catenin abnormality, but in real life, serial occurrence of hepatocellular is so common, and change or switching of the drivers occurs from nodule to nodules. So for the future, people are saying the personalized, but maybe in the case of a hepatocellular carcinoma, should be tumoralized treatment needed. And then just if you simplify, when you target where the inside the cell, most efficient one is near the cell membranes. Look at the Herceptins, look at the RAS. Even RAS is close to the cell membrane. But if you go to like deep into the nucleus or closer to the nucleus, TP53 or maybe beta-catenin, I think it can be very complicated because as you see the flat signals coming from outside and got into the nucleus. So maybe the downstream nearby the nucleus is more complicated and different routes of the river. So you can simply block it. But if you want to block it, maybe it should be near the surface. So that's the future. And then about this precision medicine, every country is developing every drugs. Right? Look at China. So many new IO is coming out. But what is unique about in Japan? What we can say about Japan by inviting the guests like Dr. Kao or Dr. Wei Lai or Vincent Wang? What we can do that? Any unique part in Japan? Well, there was in the old days, like ultrasound, small tumor treatment, and such. But now the international is becoming so competitive, and many countries can have the power, ability to develop their own. I just came back from the Beijing, came back from Korea, came back from the New Delhi, and then after the 4 years absence because of the COVID-19, I felt the strength of the power of Asia, pretty much. I'm a bit worried about the situation in Japan. Look at the numbers of the submitted papers in the GI. I'll stop here, but anyhow, I'm a bit worrisome about it. So what's I can say about the Wei Lai today, what's the situation about the precision medicine in Japan? Well, the government decided cancer prevention treatment and the major hospitals in Japan, 51 cancer centers, started in 2006. Oh, yes, 2006. So that's why we have registrations. Prospective registration, every single case is found in the hospital. So that's just I mentioned, RWD basis. The other thing started. Cancer genomic medicine projections in 13 cancer centers and 32 major hospitals started April 2023. Sorry about Japanese, but がんゲノム中核病院 got started in like National Cancer Center, University of Tokyo, Osaka, and others. And then recently, we made a Chukaku Byoin, a Kyoten Byoin, Gangenom Iryo Kyoten Byoin. This can be also the core of that district. And then we started as the affiliation, but now there is the testing, sort of, and then we promote it to be the core hospitals in Japan out of 32. Then in these institutes, we are able to conduct in the affiliated hospital as well, 300, nearly 200 over. We can conduct CGP, comprehensive genomic profilings, under the government health insurance. And then the coverage rate, the one test is 4,000 USD, but coverage reaches 7 to 90%. So the patient pay from the pocket 30 to 10%. This may be not conducted in other country. To my knowledge, about the United States, yes, there is, but they have to pay a lot. So what's the content of this CGP? And then people here knows about, but like hotspot DNA mutations, Foundation 1 is the most commonly done, 324, but Todai OncoPanel just started, 737 genes. Not just that, Todai gene top include 737 amplifications, fusion gene 455, germline mutation 40, RNA sequence 455, transcriptome 27, mutational signature. Even mutational signature we can look for. And then allele-specific copy numbers, MSI, tumor mutational burden, HRD, this is liquid gene deficiency scores. You can use olaparib by this one. But anyhow, this gene top include all sorts of things, including RNA sequencing. So maybe this is over spec, we don't know. But this does or supply the information necessary for drug interventions. So we are so excited about the result pretty soon. This will be a routine. And in fact, now the indication for the CGP panel is very limited because only the advanced cases. But probably next April, we may get started for the relatively stage 3 or 4, but after the treatment by the conventional cytotoxic drugs, this can be tested. So in other words, from now on, what we do and what we are actually doing is expert panel meetings. This is just the ordinary way. 73 years old male, unresectable pancreatic cancers, and such date he had the CT and then biopsy taken, proven. And then maybe we have a meeting like CT images, such tumor marker and such. So therefore we select. But before that, now we are having this information. KRAS G12D mutation found, and until now, we don't have any drugs. And here is the ASP3086 Luna 18 or SP141 trials going on. But at least we knew, well, we will know that what kind of driver mutation found. It's like a CT imaging. So by knowing that, not just transfer the patient to the clinical trials, but also other knowledge, other education, we are understanding the situation behind the scene cancer cells. So that's maybe comparable to the introduction of CT, introduction of ultrasound or MRI for the care of the hepatocellular carcinoma, the malignancy in general. So I think this is almost near the end of my talk. Shortest way forward is direct to drug by knowing what are the drivers. Well, in this particular case, driver means a lot because drugs are changing, gifting the change, shifting the field, like antibody conjugate with payload, ADC, or CAR T cell. So matchup means what's really drive us on, and then we can apply for that, the patients. So that's what the patients really needed in daily clinical practice. And this is 2007 Kyoto meeting, Apostle annual meetings. And next year, Professor Shina Shuichiro will conduct this meeting. And then 2025, where I just sitting in front. So my collaborators are these people. These are the people who contribute to do practice on RWD. And then these are the people conducting the laboratories. So I really appreciate Ueno Sensei in 53 years clinical experiences to give me this chance, and then younger colleagues. About 40 years of upstairs, I stop here. Thank you very much.
Thank you, Professor Omata, for this stimulus and outstanding talks. We used to don't have a question of this kind of opening lectures. So if you have any comments on, please ask Professor Omata in person after this. Thank you very much.
Thank you very much, Dr. Omata and Dr. Ueno.